Distinct honor and pleasure to introduce my good friend and my fellow alumni, Rangarayan. We call them Royal Rangarayans. Dr. Shashi Kupala. He's a neonatologist in Deaconess Health Center in Evansville, Indiana. He's the medical director of NICU there. He graduated from Rangaraya Medical College and did his pediatric residency at Cleveland Clinic and then fellowship at Cincinnati Children's Hospital. He also has a master's in healthcare quality from Thomas Jefferson University in Pennsylvania. And besides being an excellent clinician and a academician, he's also an avid hiker and mountain climber. He has already climbed Mount Everest Base Camp, Kilimanjaro, and Mount Rainier, etc. So I predict literally and figuratively he's going to climb many more mountains and peaks in the near future. And here is Dr. Shashi Kupala, our panel coordinator and moderator of the evening. Thank you and happy Navaratri to all of you. And I hope you're all staying safe as well as all your family members. Thank you.
Thanks, Ravi. I appreciate the introduction. Um, Welcome all. We've been waiting for this pediatric COVID webinar for a while now. And in this huge adult world, it's difficult to find a small little niche or place in pediatrics, but finally we're able to find it. So I really appreciate and thank Dr. Janal Gadda for giving us this opportunity to make our presence felt. We're also there in this adult world. We pediatricians. We also share the same world as you guys. So thanks to Dr. Janal for that. We have a really stellar panel of speakers today. Each one of them is so special and so distinguished in what they do. And we have a pediatric infectious diseases specialist. We have a neonatologist from Chicago, and we have a pediatric ICU consultant from UK, from Cardiff, UK. So we have very diverse group of speakers and distinguished speakers. So first, let's start with Dr. Avika Dikshit. Um, she is a staff physician in infectious diseases and at Boston Children's Hospital, and also instructor of pediatrics, Harvard Medical School. She completed her she was graduated from Kasturba Medical College in 2009, and she completed her residency in pediatrics at Riley Children's Hospital in Indiana University, and she completed her fellowship at Boston Children's Hospital and Harvard Medical School. In addition to caring for patients on the general and immunocompromised service at the Boston Children's Hospital, Dr. Dikshit spends time conducting research focused on tuberculosis within the Farhat Laboratory in the Department of Biomedical Informatics at Harvard Medical School. Her research is highly interdisciplinary, integrating infectious diseases, public health, global health, and bioinformatics. She also serves as the co-director of the fellowship program for the Boston Children's Pediatric ID Fellowship Program. So it's my pleasure to welcome Dr. Avika Dikshit.
Thank you so much. I will just begin with sharing my screen. And just a correction there, it's the co-director of the curriculum, not the program. That is a very high post that I am not worthy of just yet. Let me start my screen share here. Okay. Where's the, apologize, 1 second. Lots of screens open with all the hats that Dr. Kupala described. I have to work on a ton of things here. Hold on 1 second, I apologize. Okay. Not sure what's happening. Where is the window? It worked when we were practicing just a minute ago.
I know.
Hold on 1 second. I think I figured it out.
It did pop up one time.
Yeah.
Yeah.
Okay, let me go to full screen. All right. I'm gonna Okay, sorry about that. So, all right, everybody can see that?
Yes.
Yeah.
Great. Okay. So yeah, so good evening, everybody. Thank you for having me. Today, I will be talking to you about pediatric COVID-19. As Dr. Kupala mentioned, I must start with a disclaimer that everything with this disease is changing so rapidly. We are learning new aspects of it on a daily basis. So what I'm about to share with you may already be outdated even before I begin. So I just want to start by saying that I have no conflicts of interest to disclose. And our learning objectives today are to describe the epidemiology, the pathophysiology, and clinical features of pediatric COVID-19, including the multisystem inflammatory syndrome in children, discuss the diagnosis of SARS-CoV-2 infection in children, summarize the approach to management of pediatric COVID-19, and describe the special considerations in the neonatal period briefly. So let us begin with the epidemiology of pediatric COVID-19. Data from across the world, including the United States, has found that children are less likely to be infected with SARS-CoV-2, especially those who are younger than 10 years old. Even when infected, children are likely to have asymptomatic or mild disease. Critical illness occurs in only about 1% and is more common in those children who have underlying medical conditions. On the right here is the breakdown of pediatric cases in the US reported to the CDC as of April 2020, so earlier in the pandemic. Infants under 1 accounted for about 15% of the cases, but were more likely to hospitalize with this blue bar over here. Overall, though few children were hospitalized, only up to about 20%, and only 2% of those were admitted to the ICU. This chart here is a breakdown of the COVID-19 hospitalizations by age per 100,000 population as of earlier this month. As you can see, those under the age of 18 with these two lines here represent a minority of cases, with under 5 cases a little bit higher than above 5 in the pediatric age group. Overall, as of May, the data reported to the CDC, there was around 70,000 cases under 20 years. Hospitalization rates ranged from about 2.5 to 4%, of which about a third required intensive care and about 6% required invasive mechanical ventilation. This is a graph of cases reported in the US as of last week. Children under 5 were only about 1.7% of all cases, while children above 5 were about 7% of cases. And then coming to deaths, this is the graph of deaths in the same time period as the previous graph. Only a handful of deaths, as you can see, in double digits in both age groups here, in both pediatric age groups. Based on the data from the CDC, as compared to 18 to 29-year-old age group, the likelihood of hospitalization and death is four times lower and 9 times lower in the two age groups, and 9 times and 16 times lower for death. And then, this is a comparison group, and obviously the older age groups were higher likelihood. Similar to what has been seen in the adult population, unfortunately, children belonging to racial and ethnic minority groups are disproportionately affected. In a case series from our hospital, we reported 4 neonates, and each of those, they were hospitalized with COVID-19, and all of them had at least 2 risk factors, socioeconomic specifically, like belonging to the Latinx ethnicity, having parents who were recent immigrants, or facing housing and food insecurity, or residing in multi-generational homes, or having adolescent parents. And these risk factors were also noted in other pediatric studies from across the country. Now, I will briefly describe the pathophysiology of COVID-19, and I'll focus on a few pediatric aspects, and then I'll move on to clinical features of the disease in children. So I want to first start with the replication cycle of the virus, and you all are probably familiar with all of this. The virus enters the cell through an endosome by means of the spike protein that interacts with the ACE2 receptor, and this is facilitated by the transmembrane protease serine2 or TMPRSS2 enzyme. The ACE2 receptor is highly expressed in the lung cells, alveolar cells, cardiac monocytes, vascular endothelium, and a small subset of immune cells. The viral genome is a positive sense RNA strand, and so the cell mistakes it for a messenger RNA, and then host machinery, the host ribosome particularly, translates this into viral proteins. The viral enzymes are created first, and those help catalyze the replication of the viral genome. And then the viral structural proteins are made, packaged with the viral genomes, and new virions are made that are then released. One hypothesis for lower incidence of COVID-19 in children as compared to adults is that children have lower expression of this ACE2 and TMPRSS2 in the airway epithelium. This hypothesis is supported by the study from NHLBI, where they found a lower percentage of these two, the ACE2 and the TMPRSS2 co-expression in the respiratory cells among children as compared to adults. Proposed mechanisms of COVID-19 caused by the infection with the SARS-CoV-2 include, number one, direct virus-mediated cell damage, dysregulation of the renin-angiotensin-aldosterone system, this is a consequence of the downregulation of ACE2 related to the viral entry, and endothelial cell damage and thromboinflammation, and dysregulation of the immune response and hyperinflammation caused by inhibition of the interferon signaling by the virus. There's also T-cell lymphodepletion and production of pro-inflammatory cytokines, most importantly, IL-6 and TNF-alpha. Before we discuss specific clinical features, I want to discuss the spectrum of the disease. Again, very familiar to all of you. COVID-19 presents with an early stage that is characterized by the viral response, where symptoms are typically mild. As the disease state progresses to later stages where more severe symptoms begin to appear, the host inflammatory response becomes the main driver of the disease. In children, COVID-19 can present across a spectrum with mild to severe acute disease over here, or presenting with an inflammatory syndrome called MIS-C, which itself has been described as a mild febrile illness or a KD-like illness, or even up as a severe disease. Symptoms of COVID-19 in children can range from mild respiratory symptoms to respiratory failure. Gastrointestinal symptoms have also been described. Lab findings are variable. Studies have found low WBC count in up to 17% of children with either neutropenia or lymphocytopenia in about 13%. There may be elevation of inflammatory markers. Imaging findings are also variable and may show ground glass opacities of consolidation with up to 50% of children with confirmed COVID-19 showing abnormal imaging. A rare but serious syndrome called the multi-system inflammatory syndrome in children, or MIS-C, has been described, mainly from Europe and North America. Some of the features are similar to Kawasaki disease, as well as macrophage activation syndrome and cytokine release syndrome. But there's distinct immunophenotypic features that are associated with MIS-C. It typically occurs 3 to 4 weeks after the infection, the acute infection with the virus, in otherwise healthy children. And majority of the cases are seen in the 8 to 11 age group, with Black and Hispanic children accounting for a disproportionately higher number of cases. The pathophysiology is not completely understood, but it's thought to be a post-infectious immune dysregulation state. Although some deaths have been reported, majority of the children do recover. So this is a map of the US showing cases reported since surveillance began in mid-May by the CDC, and they've been reported from almost every state now. Various agencies have put forth case definitions of MIS-C, and they vary slightly. Generally, symptoms of MIS-C include fever, which is almost seen in almost all cases, gastrointestinal illness, rash and conjunctivitis with shock and cardiac dysfunction. Labs usually show elevated inflammatory markers and coagulopathy, with elevated troponin or BNP. A brief note about transmission. Data is limited because of school closures during the pandemic. Children have not usually been a source of infection in studies that are available, and younger children may be less likely to transmit. Reasons remain unclear, but potentially due to the lower expression of ACE2 that I mentioned earlier. Now coming to the diagnosis of this infection in children. The American Academy of Pediatrics provides guidance on who should be tested. Certainly any child with symptoms consistent with COVID-19. And since co-infections with other respiratory viruses have been reported, such as influenza and RSV, testing positive for another respiratory pathogen should not preclude SARS-CoV-2 testing. Close contacts of confirmed or probable cases should also be tested. And testing of asymptomatic children presenting for medical care varies from institution to institution. RT-PCR remains the best test for most cases. It is highly sensitive and specific in the ideal setting, but it cannot distinguish between the presence of the virus, just the RNA, versus an active infection. So patients may still test positive even after their symptoms have resolved. Nasopharyngeal swabs are thought to be the most sensitive, though oropharyngeal and anterior nary swabs have been used with some success, and studies using saliva are ongoing. Antigen and antibody tests have been developed. Antigen tests are generally less sensitive than PCR tests. Antibody tests are not useful for diagnosis in early disease. The sensitivity and specificity is highly variable depending on the assay used, And false positives can occur due to cross-reactivity with other coronaviruses. And we yet do not know what a positive test means for immunity. There are a few innovative testing methods currently under study, including a breath test, but it remains to be seen whether they can be widely implemented in the clinical setting. Now, briefly about management, please note that data on optimal treatment of pediatric COVID-19 is extremely limited. Management, of course, varies by severity. Mild to moderate disease where the patient has no new or increased supplemental oxygen requirement may be managed with supportive care as an outpatient, while severe to critical disease requires hospitalization, critical care, and multidisciplinary inpatient management with consideration of use of experimental therapies. For mild to moderate disease, besides supportive care, parents should also be educated on the warning signs and subsequent monitoring for MIS-C. Working in coordination with local public health departments for infection prevention, isolation, and contact tracing is essential for outbreak control. Children who have severe or critical disease, in addition to appropriate supportive care, the risk and benefits of experimental therapies must be weighed on a case-by-case basis. Patients should be enrolled in clinical trials where available. No established therapeutics are available for the treatment of severe or critical COVID-19 in children. There are several therapies currently under evaluation. Remdesivir is an antiviral that you're all familiar with, which acts via the inhibition of the viral RNA polymerase. Data on its use in adults continues to emerge, and there's currently an ongoing trial for children in the United States, for which our hospital is one of the sites. It is also available for use in children through an emergency use authorization through the FDA. Low-dose corticosteroids have shown to reduce mortality in adults who required oxygen or mechanical ventilation, and they're currently being evaluated for use in children. Additional therapies under evaluation include anticoagulation, convalescent plasma, and immunomodulators, as well as monoclonal antibodies. Data suggests that hydroxychloroquine and lopinavir/ritonavir lack efficacy against COVID-19. This slide shows data from the use of remdesivir for treatment of pediatric COVID-19 through a compassionate use program. In a multi-site study, including our hospital, 77 children were treated with remdesivir. Clinical recovery was observed in 80% of children on ventilators and ECMO, and 87% of those who were not on invasive oxygen support, this row here. The drug was generally well tolerated and no new safety concerns were identified. Transaminase elevations were associated, they're already associated with remdesivir and severe COVID-19 illness in adults, and they were also observed in children, but they were not high enough for any remdesivir discontinuation. Dosing recommendations for children are available. Treatment duration for severe disease is typically 5 days, but can be extended till 10 days. Remdesivir is not recommended in hepatic impairment and in certain cases of renal insufficiency. Co-administration of hydroxychloroquine is not recommended due to potential antagonism. A variety of chemokines associated with cytokine storm syndrome in acute COVID-19 have been identified, including interferon gamma, interleukin-1, interleukin-2, interleukin-6, etc. There may be a role for immunomodulators, preferably in the setting of a clinical trial. Tocilizumab, which is an IL-6 inhibitor, and anakinra, which is an IL-1 inhibitor, have been used, but no studies supporting use in pediatric COVID-19 are available to us. Data on glucocorticoids in pediatric COVID-19 is also limited, but these can be considered for critical patients. Convalescent plasma is available through the FDA for COVID-19 through an EUA. Evidence is again limited, and there's theoretical risk for antibody-dependent enhancement of infection. IVIG and interferon are currently not recommended for use universally. A brief note about the management of MIS-C. Management is multidisciplinary, involving pediatric subspecialists from rheumatology, ID, cardiology, hematology, and intensive care. Treatment is mostly supportive with directed care and discussion with the subspecialists. The role of antiviral therapy is uncertain, and antibiotics may be used early in the disease while bacterial sepsis is being ruled out. And then briefly about neonatal considerations, I know we'll hear from the neonatologists later. The risk of transmission to the neonate varies between the antenatal, perinatal, and postnatal period. Data are limited, but so far indicates that the postnatal period likely poses the highest risk of transmission. Based on a few case reports, vertical transmission seems possible, but rather rare. And the risk of acquisition postnatally from an infected mother is estimated at about 2 to 5%. Breastfeeding is not contraindicated, even though SARS-CoV-2 may be present in breast milk, because the benefit outweighs the risk. In a meta-analysis of 133 neonates with COVID-19, breastfeeding was not associated with late onset COVID-19 infection. Most organizations, including WHO and the AAP, changed their original recommendation and now recommend against separation of infants from mothers with COVID-19 after delivery. And mothers with COVID-19 should perform hand hygiene and wear a mask when handling their newborns. Although infants are at a higher risk of severe disease than older children, the vast majority of infants infected with SARS-CoV-2 do quite well. Our hospital's best practices include using RT-PCR for diagnosis of SARS-CoV-2 infection. Because data on optimal management of children with COVID-19 are limited, for children with severe or critical disease, specific treatment options such as remdesivir and low-dose corticosteroids and other immunomodulators can be considered on a case-by-case basis, ideally as a part of a clinical trial. Clinicians should be aware of the possibility of MIS-C, and breastfeeding and rooming in with infection prevention measures are recommended in most cases for infants born to mothers with COVID-19. So to summarize in 8 bullet points, although children can acquire SARS-CoV-2 infection, they're typically less severely affected than adults. Infection is best diagnosed with RT-PCR from a nasopharyngeal swab. Most children do well with supportive care and rarely require hospitalization and intensive care. A minority of children may develop MIS-C a few weeks after the acute infection. There is very little data on optimal treatment of severe or critical disease, but experimental therapies may be considered as a part of a clinical trial. Infants of mothers with COVID-19 generally have excellent outcomes, and breastfeeding and rooming in are recommended with infection prevention measures. Here's a summary of resources for both adult and pediatric COVID-19, and I'm happy to share any references from my talk that anybody might be interested in. Today, I presented to you collective knowledge from the clinical faculty and fellows of our division, pictured here in a pre-pandemic photo. Particular thanks to Dr. Nakamura and Dr. Brennan Crone for their contribution to these slides. And I have 2 career development grants that I would like to acknowledge here as well. So that's all I had. I will leave up the resources slide in case that's helpful, but we can start with the next speaker if needed.
Thanks, Dr. Dikshit. Really appreciate it. Great talk. Thank you. We can take the questions at the end.
Okay.
This talk is recorded anyway, so they can see and access the references once the talk is finished.
Okay, I'll stop my share so the next speaker can share.
Thank you. Appreciate it. All right. Again, we'll take the questions at the end. Our next speaker is Dr. Shiva Oruganti, and he's a consultant pediatric intensivist at the Noah's Ark Children's Hospital for Wales in Cardiff, United Kingdom. He's a graduate of Rangaraya Medical College, Andhra Pradesh, and he also completed his MD Pediatrics in India, in Andhra Medical College, Vizag. And then he moved to the UK, and he has been working as a pediatric intensivist in Cardiff for some time now. He's a local research lead for Cardiff, and he's currently the principal investigator for a study to investigate biomarkers in sepsis and COVID in children. He got the preliminary work done, he got the Ethics and Health Research Authority approval done, and he's about to start his project. One more thing, this is well past 1 o'clock, 1 a.m. for Dr. Oruganti, and we really appreciate your patience and commitment towards this talk. He's also on call, so he has to find somebody else to cover for him during his talk. Thank you so much, Shiva. Welcome.
Thank you, Sashi, and thanks for the kind words. Thanks to you, Dr. Sudhakar Junalagada, as well as Dr. Ravi Kohli for giving me this opportunity. And I'm really glad that there is a nice group of audience for the webinar. And so I'll start by sharing my screen. And I think I would like to start off by saying that COVID has certainly touched everyone's life without any exceptions. And what I would certainly like to mention is, for some, it has been much closer to heart due to involvement of either somebody close in the family or among friends. So can you see my slides? Can you hear me?
Yes, we can.
Okay. So this talk was supposed to be about clearly about COVID, and because we are talking about pediatric COVID, about MIC, or the multisystem inflammatory syndrome in children, or PIMS-TS, which is the name for the same condition in the UK. But I thought I'll just start off by talking about going back a few months and going through the journey as a pediatric intensivist over the last 6 months. And certainly I would like to thank Dr. Avika Dikshit, who in a way has actually made my talk easier by covering most of the difficult aspects of COVID pathophysiology and clinical features. So back earlier in the year, in February or late January, we knew that there was this raging epidemic which started in China, and we feared there would be a pandemic. But we knew that in children, it was either mostly subclinical or causing only mild clinical symptoms in most of them, and the outcomes at that time we knew they were really good. The main worry was about involvement of elderly and adults with comorbidities with very poor outcomes. What we anticipated was a huge surge with increasing demand for adult ITU beds. And most of our planning at the time, supported by the Pediatric Clinical Care Society, was about guidance, providing guidance to protect staff, as well as making sure we support adult ITU capacity as well within the hospitals. And in the UK, we have the National Health Service, which is a public service, which is free of cost at the point of care. And it is all very closely orchestrated. There have been subsequent guidance there has been guidance from the Pediatric Critical Care Society, which was previously called Pediatric Intensive Care Society, on managing COVID-19 and PIMS-TS. So, but it soon, even before the Pediatric Critical Care Society was able to give the guidance, it was very clear that we would just have to deal with the situation depending on our regional situation and needs. So most of the response was devolved to local areas. Depending on the incidence of COVID in the region, it was the highest in London, depending upon the adult ITU capacity needs, and also prioritizing children's service provision as well. At that time, when we did not know much, we still do not know a lot, but earlier in the pandemic, we did not know much. And what really helped was this huge network of intensive care doctors and staff who were more than willing to help and share their experiences. We had a social networking site with about 1,200 to 1,400 intensive care doctors and nurses who were taking time despite their busy work from places like Italy and Spain and China and also in India and the US, sharing their experiences, sharing their guidelines, sharing simple practices which seem to work for them, and things which they felt would not work. And a big part of this was having a multidisciplinary team involvement of various other specialties and allied professionals coming together to work it out. An example of some of the practices shared, even though we never had to use this, is how we would split a ventilator to ventilate 2 patients. And this was because of the worry that there would be a huge shortage of ventilators. But thankfully in the UK, we never had that. And so
Shiva,
there
to
was this.
interrupt you, are you forwarding your slides? Because we're on the first slide only.
Oh, sorry.
Yeah.
You're not seeing, are you?
No, we're not seeing any slide for moving forward.
Okay, okay.
You may have to put it in the
I'll have to
presentation
start
mode.
again. Yes. Shall I try to use my cursor and see?
How about putting it in the presentation mode, Shiva?
How about now?
How about putting it in the presentation
Go to
mode?
the slideshow tab and then go to the
Oh,
start.
sorry. Yeah. I think it does seem like it's in the. Shall I start again? Stop sharing, and apologies for this.
No, no, you're
Just
okay. No,
quickly
this is a
move to
great
that
talk.
slide. Yeah, I don't think we got into any data points.
Right. Okay. Um, so I'll try again.
I know it's late in the night. It's kind of a little bit tiresome.
Can you see the screen?
But go down, further down the slide set, or click down button and you'll go to the next slide.
Can you see it moving now?
No.
No.
I think when you
Oh,
go to
yeah.
presentation mode, it doesn't move. It just stays on this.
Okay. So, oh, right. Okay. So what you're saying is try not to go into presentation mode. Is that what you're saying? Okay. I'll try and do
Yeah,
that.
I think that's what's happening. You click on presentation mode and it stops moving.
Okay. Yeah. I'll try again. Um, can you see it now?
We see your cursor moving. Yeah, that's good. You're good.
Is it better now?
Yeah, you're on the second slide. If you keep going to the each slide,
Right.
you
Yes.
see that.
Yeah. Okay. Okay.
Good.
Sorry. Okay. Yeah. So yeah, sorry, I was going to share. I think I'll probably, yeah, I think you did not really miss much.
Right.
It was more a narrative, really.
Right. Yeah, please.
And as I was saying, I thought I'll share my experience and our experience as a pediatric ICU team. And what really seemed to help was the huge network that was created very, very quickly. Within weeks by intensive care doctors and staff. We had this social networking site with nearly 1,400 to 1,500 doctors and nurses sharing their experiences. And the multidisciplinary, the specialities and allied professionals coming together to sort of more or less troubleshoot and come up with solutions. And I was showing you this, you probably haven't seen this, how there were discussions about how we could actually split a ventilator to ventilate 2 patients with the fear that there would be scarcity of ventilators, but we never had that. And one of the key issues was this iterative process of simulation and training and retraining. And the focus at that time was, even now, it is mainly about protecting staff, because that is a big worry in pediatric ICU world. As Dr. Dikshit explained, certainly COVID affects adults more than children. And in the UK, within PICUs, as I explained, with a worry about shortage of adult ITU beds, we actually had 3 options. One was to just lend the whole unit with infrastructure to the adult ITU doctors, so that and then move or decant or service to other areas, or reorient our pathways so that patients who would normally come to our PICU go to other units in nearby cities. And the third option was help out with the adult ITU capacity by admitting some of the young adults into PICU and manage them ourselves. And we chose the third option. There's a feeling among pediatric intensivists that the third option was probably the most difficult, because sometimes the protocols and the way the adults are managed certainly are very different to how children are managed. A key aspect I thought I'll touch upon, which talks about COVID, is not really sort of discussed, is the delayed presentations with other health problems that certainly I have seen and our team have seen. Stuff like infections, other infections presenting very late, or problems, even though being referred to general physicians or specialists, due to lack of direct face-to-face contact and telephonic consultations, there were delays. Certainly, there have been waiting times which have gone up significantly. And there's this worry about cancer treatment, but I'm not aware of that actually being affected in children specifically. Christakis in Journal of American Medical Association has discussed how there would certainly be some long-term effects 10 to 15 years from now, where children who miss school, miss the social interactions, and rely on online schooling and the lockdown may have. One of the big things that I certainly missed is that the routine PICU research was paused for nearly 3 months, which has affected advances and research in other areas of medicine. So coming down to COVID and SARS-CoV-2 incidence. So initially, it was very clear that the incidence was much lower in children. But when we talk about incidence, I thought I'll just make this point just to supplement Avika's discussion on the epidemiology. What we can only comment on what we actually test in children. And there's this huge, and we only are seeing the tip of the iceberg. And there are huge numbers who just are not tested, especially in UK and Europe. In China, when they were testing quite a lot of children, even then they were only testing those who were close contacts of suspected or confirmed cases. And it was about 12 to 13% there. And very few patients, less than 2%, were being admitted to PICU. In other countries like Spain, they found that among those they tested who presented to hospital, about 11 to 12% were coming back positive. But the usual numbers or the proportion admitted to PICU following hospital presentation has been around 10 to 15%, with similar figures in the USA and Europe. So the data we have is from a data registry in UK. We call it the Pediatric Intensive Care Audit Network. And we submit this data to this registry. And evaluation of this data over a 12-week period up to 13th of June from mid-March showed that there were about 71 children with positive SARS-CoV-2. And we usually submit the data as episodes because it is anonymized. And there were 73 episodes. And the median age, as you would expect, is about 9 years, so older children. But even children as young as newborns were admitted as well. And the demographics, as you would expect, non-white Caucasians are disproportionately represented in children admitted to PICU. Of these children admitted to pediatric ICUs in the UK, a major proportion were invisibly ventilated, and at least half of them were on vasoactive infusions for shock and hypotension. and 5 of them went on to extracorporeal life support or ECMO support. And I think I thought I'll just touch upon invasive ventilation just as a point of interest, really. When the pandemic first started, and we were talking to our adult ITU colleagues, there was this huge anxiety to use non-invasive ventilation like CPAP via mask or BiPAP or high flow, because of the worry that there would be cross hospital staff infections and then sickness leading to disruption in service. However, we soon realized that with due precautions, we can still provide non-invasive ventilation like high-flow CPAP. And in fact, personally, I feel that actually that has helped in improving outcomes in adults as well as in children. Because invasive ventilation certainly has its own problems leading to iatrogenic complications. And this is a case series reported by Lara Shekhar-Damian, who is a pediatric intensivist in the US. This was for a very short period. It was like a cross a point prevalence study for 3 weeks with a follow-up after a week. And there were about 48 children. And again, as you would expect, the median age was 13 years. And a majority of them presented with respiratory symptoms. Invasive ventilation was about 40%. Some of them, one patient was on ECMO. And it is interesting that even though in the PICUS report, it wasn't clear, a major proportion had comorbidities and the mortality, there was mortality in a couple. In terms of the clinical features, I think needless to say, most of them or a majority presented with shortness of breath. And what is remarkable is this description of a happy hypoxia, where we would have teenagers browsing their mobile phones, sat happily, but needing 70–80% oxygen on ventilation, on non-invasive ventilation. And there have been reports of gastrointestinal symptoms and neurological symptoms as well. Even though we expected it would be more like an acute respiratory distress syndrome or acute lung injury, COVID is now recognized as one of the causes of sepsis or viral sepsis, and with multi-organ involvement. And there have been, as I mentioned, severe neurological complications. We have seen patients with diffuse microinfarcts on cerebral imaging, may be related to the microthrombi or vascularity picture. It's not very clear as well. In terms of the management, I thought I'll just touch upon some of the specific treatment. At the start of the pandemic, as you're all aware, we were not sure what would work, but whatever treatment was offered was in the context of the clinical trials recovery in the UK. And currently, even with the recovery, dexamethasone has become the standard of care even in children. We do have access to remdesivir as an antiviral treatment. And I looked into use of remdesivir as representing our unit, because the outcomes were generally fairly good, have been generally fairly good in children. We decided we would only use remdesivir in immunocompromised patients, but we never had to use it. I know that my colleagues in Great Ormond Street Hospital have used it. And personally, I feel that because it is an antiviral agent, which works on RNA polymerase, and as Dr. Dikshit earlier described the pathophysiology, where the severe manifestation of the disease is more due to the host immune response, remdesivir is perhaps better if started earlier, maybe at the start of oxygen, but that's my own personal opinion about it. and we would say certainly need more trials. Supportive management, as has been discussed before, and as I mentioned, key would be trying non-invasive respiratory support in these patients. And good hydration is absolutely essential because of the risks of microthrombi in patients. Use of anticoagulant therapy. We've put all our patients on anticoagulant therapy. As I mentioned, ARDS is one of the severe manifestations, and we would use certainly prone positioning, even in awake patients, which is unusual. We had never done that before. And mechanical ventilatory strategies for ARDS, like low tidal volumes and open lung ventilation with high PEEP, and targets as suggested by the Pediatric Acute Lung Injury Consensus Conference were used. We followed these pathways and guidance. And Dr. Dixit mentioned some of the immunomodulated treatments, and all of these treatments, even now, and they've always been in the context of the recovery trial. I'll mention a little bit more about the recovery trial a bit later. And this, the treatments available through the trial are IVIG and methylprednisolone, convalescent plasma, and tocilizumab, which is an interleukin-6 receptor antagonist. Outcomes, as we know, are generally good, and obesity is a huge risk factor. There's been a recent systematic review looking at all the evidence so far, which has come up, and obesity is one of the highest risk factors for severe COVID. And there is clearly an overrepresentation of Black, Asian, and other ethnic minorities in the Western world among those who have severe disease and poor outcomes. So talking about PIMS-TS, which is the other name for MESC or multi-system inflammatory syndrome, it was first described by the South Thames Retrieval Service in the Lancet, where they found epidemiologically very interesting, a cluster of about 8 children. Normally they would see less than maybe one patient every few weeks, but then they suddenly saw a huge jump in 10 days of 8 children with what seemed like an atypical Kawasaki's disease or toxic shock syndrome. And we've gone through the clinical features from the earlier speaker. What's interesting is this raging systemic inflammatory response syndrome with fever, rashes, and very rapid deterioration in these patients with very elevated inflammatory markers and involvement of the heart in a huge proportion of these patients. One of the key things about the clinical features is the GI symptoms in these patients. And there have been at least 2 or 3 children where they were referred to the surgeons and had exploratory laparotomy, suspecting an acute surgical abdomen, but they could not find anything. And that became like one of the confounding factors for managing other problems in children. So we had guidance from the RCPCH for managing PIMS-TS. In addition to UK, or more or less at the same time in Europe, even though they're called by different names, it's called the SICK syndrome. They reported case series, and then this is the one from the US. A characteristic feature is most of these patients are negative for PCR or viral antigen by the time they have this problem, but a large proportion of them have antibody, and hence the hypothesis that it's an immune-mediated problem. So I thought I'll just present a case series that the UK PICUs published, which from the data that we had from PICUs. And this graph shows very clearly the expected sort of cumulative number of patients from other inflammatory conditions around this period. And this green line shows a certainly much higher number of inflammatory multisystem inflammatory problem, children with multisystem inflammatory disease around this time, showing that this possibly is not epidemiologically normal as part of presentation, and hence the link to SARS-CoV-2. So this case series, we had 78 children, and the median age was 11 years. And many of you would remember, even though this is called an atypical Kawasaki-like or atypical Kawasaki disease with shock or toxic shock syndrome, the big difference is the age. You may remember in Kawasaki disease, it's very common under 5 years and very unusual after 5 years. But we were seeing this among the older children. And certainly the ethnic minorities, the Black, Asian, and ethnic minorities were overrepresented. And the clinical evolution was very, very rapid. Within hours, within day, they would be very, very sick, in shock, on multiple inotropes and vasoactivations. Coronary abnormalities were seen in up to 40%, and they were in the form of echo bright shadows or coronary aneurysms. And that's another difference between what we noticed anecdotally in our hospital was the very rapid progression to big coronary aneurysms in the couple of patients we saw with coronary aneurysms, which is unlike Kawasaki disease. And half of them were invasively ventilated. Huge proportion needed vasoactivations. 3 of them were on ECMO, and 2 children died. So it is a pretty nasty clinical syndrome. And the treatment over and above organ support has been, again, in the context of the recovery trial. However, even though with SARS-CoV-2, certainly the treatment was in the context of the trial, pediatricians and specialists were reluctant to actually wait, and they would we were starting treatment with IVIG and with alprednisolone high dose very early on without actually even waiting for randomization into the trial. Cardiology input was of course, has been very important. A key feature when we started seeing these patients is developing a pathway, a referral pathway, so that these patients could be referred to the specialists very early into their illness. It's also helped in sort of training and educating pediatricians in Wales. And almost every other region in the UK had a pathway similar to this. Sorry about the busy slide, but this is more just a demonstration as to, for all the pediatricians and ED physicians and other specialists to identify and then follow the referral pathways without wasting time, because of the rapid evolution of this syndrome. So I know that, in fact, I hope you were not expecting that we would come up with sort of a solution, but yes, we do have treatments. And I thought, even though we haven't seen the back of or the end of this saga of COVID pandemic, I thought I'll end my talk on some positive learning points. And one of the key learning points for me as a research lead was the role of research in managing COVID. And ISARIC, you probably may not have heard, or you may have heard about it, is a WHO-supported clinical characterization study, which was steamrolled within maybe 2 or 3 weeks of the start of the pandemic in March. And one of the learning points for me was that having just gone through the ethics and HRA approval for a single site study, to actually start something within a few weeks is almost would have been almost impossible, but for the foresight of the chief investigators and the research teams for the ISARIC to actually plan for something like this, even though they did not know that we would have COVID. They had planned for a pandemic during the flu pandemic and had generic protocols which they could roll out at very short notice. And the other learning point was about studies such as recovery and remap cap in the US. These are trials which are um, almost like they've broken sort of records in flexibility and sort of using multiple treatments. So the advantages are that they have multiple treatment arms. So clinicians can actually go through step by step as to what treatments, depending on the patient's journey and severity of illness, the patient would need, and then randomize to standard care. The other great feature is using adaptive design. So, as Dr. Dikshit mentioned, research is still ongoing. If somebody comes up with a new treatment, they can actually incorporate the new treatment into this trial without any disruption to the study or to the clinical care. And they offer huge flexibility to the clinician so patient care is not compromised. The other big learning point for me is the networking, how networking helps. Some of you may already know, UK, because of the NHS, care is heavily protocolized and there are guidelines for everything, protocols for everything. And then we were in this situation where we were groping in the dark. And this is what helped us, having this network of doctors from all over the world sharing ideas. Certainly for me, and I'm sure for others, it then sort of reorientated my values to the importance of family and friends, and certainly during the lockdown, well-being. And I'd never done dance, and we took up Bollywood dancing during our spare time, which helped us a lot. Thank you very much.
Thank you, Shiva. That was a phenomenal talk. Thank you so much. We'll take the questions in the end. If you could hang around if possible. Um, our next speaker is Dr. Janardhan Maida. He is an attending neonatologist at John H. Stroger Junior Hospital of Cook County, and he's also adjunct assistant professor of pediatrics, Rush Medical Center, Chicago. He's a graduate of Gandhi Medical College, Hyderabad, and he also completed his MD pediatrics there. And he completed his residency in pediatrics in Wayne State University, Detroit, and completed fellowship at the John H. Stroger Junior Hospital of Cook County. His research interests include neonatal public health and epidemiology, and he is specifically interested in studying how the racial discrepancies impact the birth outcomes and how the length of stay in America affects the birth outcomes among Black, Latina American children. Welcome, Dr. Janardhan Maida.
Can you hear me, Sashi?
Yeah, we can hear it.
All right. Thank you for the introduction. I'm trying to share my screen.
Did Dr. Shiva stop sharing? Then you can go ahead.
I think I have.
Okay.
Have I?
Yeah.
Can you see my screen, Shiva?
Yeah.
All right. Let me just scroll a couple of slides to see if I can move.
Yeah, you're good.
All right. Thank you all. Thank you, Sashi, for giving me this opportunity. So I feel privileged to share this webinar presentation along with the speakers from eminent centers across the world. So I'm a neonatologist. I work in Chicago. I do a bit of research in collaboration with the Rush and Northwestern. As Shashi was mentioning, my main research areas include racial discrepancies and birth outcomes. And also, we have been doing some collaborative research on COVID, especially in pregnant mothers, placental placental effect on COVID mothers, and also newborns. We just submitted our work to the 96 Symposium Perinatal Conference, which we are going to present next month, and submitted a couple of papers to the Green Journal. We're waiting to hear from them. So I would like to present mostly my on the newborn COVID affected mothers and then how the newborns are presenting. Before I talk about the newborns, I would like to talk about like how the pregnancy COVID virus affecting the pregnancy mothers. What is the role of these infections on the placenta? How is it any evidence that there is a vertical transmission? That means mother to the baby is there or not? How we are going to manage these babies? I mean, what's the guidelines currently existing? So as we all know, there's a little bit background of the coronavirus. Are you able to hear me? Sorry, my voice is little.
Yeah, we can hear you very well.
All right.
Thank you.
So as we all know, coronavirus is a positive stranded RNA virus. They are kind of like in 7 different coronavirus. But if we look at the history of these coronavirus, every 10 years, it's kind of throwing an epidemic. As we can see, SARS-CoV, which happened, I think around 2004 in North Korea, which has kind of really, I mean, is in Asian countries. It was in a big pandemic epidemic at that point. And then a similar virus, but much more infectivity and much more serious than the SARS-CoV-2 was Middle Eastern respiratory syndrome virus, which was 10 years, almost 10 years after the first one, around 2014. So the interesting point related to the pregnancy and newborns related to MERS was there were 5 pregnant women which was affected at that point. Out of the 5, 2 maternal deaths was there, and there was a 1 stillbirth, and 1 neonatal birth was like a stillbirth and neonatal birth after the emergency C-section. And then looking at the vertical transmission from the history, the evidence was not that great for the vertical transmission even in the past too. That is transferring the virus from the mother across the placenta to the fetus. However, there were stillbirth reported at that point. Is it because of the really bad clinical status of the mother? That's mostly the reasons which was happened in the stillbirth back then. And if you look at the evidence, the limited evidence on the effect of newly discovered SARS-CoV and maternal and infant morbidity and mortality. We all know it is it was a zoonotic virus. It was stayed there in pangolin, which is not causing any disease. From there it went to bats, and then from there we got it from Wuhan, China. So I would like to just stress in a point about the receptors, which is kind of become an interesting point for the research standpoint, especially in the placenta, as Dr. Dikshit and then Dr. Shiva was mentioning. The angiotensin 2 receptor is kind of a main receptor area for this virus to entering into the cell. And then lately, people are looking at the placenta. There are quite a few of these receptors exist there. So which favors towards a vertical transmission. However, clinically and immunologically, it's not favoring. So there's a lot of missing information is going on between those two.
This virus works by hijacking a receptor in your body. It takes this receptor, uses the machinery of the lung, and actually replicates and infects the lung to the point of fibrosis.
And that's in the lungs. We all know that they have it. Dr. Dikshit was saying the angiotensin 2 receptors in the children's are kind of less. But what about these receptors in the placenta? Actually, the evidence has shown that quite a few of these angiotensin 2 receptors are there in the placental histology. So if we look at the pregnancy mother and then how different she is from the other population. And we all know there's quite a few immunological changes occurs during the pregnancy, especially during the trimester is pro-inflammatory kind of stage. A lot of physiological changes, especially increased female sex hormones that will promote the secretions in upper respiratory tract, which might have more like kind of risk factors for the colonization of this virus in the nasopharyngeal area. So this is I just kind of summarized all the literature so far published related to the mother and the babies. So it's all started in kind of end of February and beginning of the March, when the first 9 pregnant women publications from the Wuhan published in Lancet. That's just they describe the clinical features, how they presented, and then most of them there was no morbidity at that point. Followed by there's a tons of research being published about the pregnant mothers and placenta and the babies. So in the March, there are kind of two major studies. One of them has described 33 neonates of COVID-19 that was published in JAMA Pediatrics back in middle of the March, and the three was infected, and then babies for the three was infected, but infected in the sense they are the test positive, but they were not symptomatic. And then at the same point, JAMA published from the data from the Wuhan again, and they at that point they said there is a vertical transmission was there because they detected some antibody serology in the cord blood, and then there was everybody was panicked, and then at that point actually in Wuhan they are kind of doing a C-section on all moms, thinking that vaginal delivery is kind of more prone, just like in HIV. A lot of confusion was there. However, from March till now, the thought of having a vertical transmission from mom to baby is kind of fading a little bit, I would say. I don't know moving forward from now that might come up, but as of now, the evidence is not that strong as we were thought in March and April. And so this was one of the scary study, I mean, published from Iran in collaboration with Texas Children's Hospital. So there are the 9 pregnant women who are critically ill. I think they include their study in, I think it's published in Green Journal. 9 pregnant moms who are 7 died, but they're very, very, I mean, the data includes all the sick moms. Out of them, the 11 babies were there. A couple of them were twins. 6 babies were died. I mean, most of them, these 6 babies who died were the very premature babies of 23, 24 weeks. So at that point, when they published, is the babies died because they got infected from the mom or other comorbidity. When we look at that paper closely, it's because of the other comorbidities, and then mom was so ill because of the coronavirus rather than the actually direct infection of these virus to the babies. They were tested out of the 11 babies. I think they tested most of them. The test was PCR was negative, and followed by in May a couple of papers published. Then the first publication from the CDC, I would say she was CDC reported in the middle of April, 143 pregnant women. Out of them, 4 were ICU admitted. Wait. My kid is coming, sorry. So the first placental study was published in July. That was from the Northwestern. They kind of tried to see what are the placental changes what is seen in these pregnant moms. They said that there is a lot of villus agglutination, and then chorioamnitis kind of pictures with us kind of statistically significant compare when they control with the same placenta with a similar pathology. They attributed there were placental changes which we can attribute to the COVID. However, those findings were kind of non-specific. The papers which were published after that does not really support it, or the consistency of the evidence was not actually reported. I just minimize this. So these are like there are other placental studies which was reported in June. at 22 weeks of gestations shows in a coagulopathy, and then followed by 179 infants. This was a recent studies in September. Self-reported case 179 infants who are positive, and they went back and looked at it. Out of this, 84 infants were mothers were positive, and mothers, sorry, 179 infants mothers were positive, and then 84 infants were who was positive, so mothers were kind of negative. So these babies got this infection after the discharge from the community, or from the visitors, or is it from the mom, is kind of little controversy. So mostly it looks like is it just at the time of the delivery, could be from the mom, but is it from the moms during the delivery when related to the delivery? It looks like a very unlikely. So more than about like 300 studies so far was kind of published in a mother and baby dyad, and including the placenta. This is one of the most recent meta-analysis. They included around 13,000 papers, including 83,486 non-pregnant women of reproductive age COVID-19, 13,118 pregnant and recently pregnant women. So 26 studies was talked about the prevalence of COVID-19, 52 risk factors, and 40 papers were clinical manifestations, 49 papers talked about the COVID-19 related outcomes, and 39 pregnancy related maternal perinatal outcomes. So based on that papers, what we have learned is how prevalent is the infection among the pregnant women. Looks like 10% of pregnant women are admitted to the hospitals. What are the most common symptoms? 4 out of the 10 infected women show symptoms, fever as well as cough. How symptoms differ from a non-pregnant woman? Pregnant women are less likely to have fever and myalgia. How severe is the disease? Pregnant women are 1.5 times more likely to be admitted to the ICU because of an associated, pregnancy-related comorbidities or pregnancy-related change in pathophysiology. Pregnant women are almost twice more likely to get an invasive ventilation. 1 in 1,000, that is 0.1% of COVID-19 infected women died. What is the effect of COVID-19 infection on a pregnancy outcome? Pregnant women with infections are 3 times more likely to undergo preterm delivery. Is it because of the stress related, or is it because of the virus itself? It is unknown at this point. So this is the latest CDC data. This is something interesting. I mean, the number of cases of COVID is more during this age group, 25 to 29 of year. As Dr. Dikshit and Dr. Shiva was mentioning, and there's quite a bit of ethnicity and then racial and ethnicity inclination toward the COVID infection, which we have seen in our practice and experience as well. Hispanics or Latinos are kind of affected more in the pregnant women compared to Black non-Hispanics. But whereas Black non-Hispanics or African American ethnicity in the elder people is kind of more affected compared to in a pregnant. How many pregnant cases so far? 25,351. And out of them 5,963, 23% were ICU admitted. Total deaths so far is 44, less compared to in a general population. So that is just a Illinois regular COVID infection rate and deaths. So when we looked at I think this is from infectious disease analysis from the WHO. This is informed estimates of parameter of onset to death in a pregnant woman, which is more or likely same as in a general public. Onset to recoveries, usually they looked at the 29 mothers, 29 data points, which shows 22.2 days within a standard deviation of 0.45. Same as onset to the death, if anything happens, is around like that period, 3 weeks period. So we looked at like 2 hospitals data of the pregnant women, the babies here, to look at what are the risk factors for these mothers who are symptomatic, which is influencing this disease severity, what is the potential for the vertical transmission, and how the placental histology is kind of affected. is the disease of the mom is affecting the baby in terms of symptoms or in terms of an admission to an ICU? Are there any changes in the lab parameters in these babies? And we looked at it, I think, from April to the mid of July in two different hospitals over here in Chicago. We looked at like 4 months, 3 months enrollment period, and then almost like 4 months period. So of 37 mothers, we excluded 3 because of the data issues. 15 moms were symptomatic and 19 moms we found not symptomatic. There are stillbirths, 2, those are twins. Babies died. I mean, there was no heartburns when mom came in, and we don't know the reason of it. It's not unlikely. It looks like in a COVID related. So the interesting thing is none of these babies were tested positive. We tested times 2 with a 24 hours gap at 24 hours and 48 hours. None of these babies were positive. Negative and 28, and test not done on 8. We did not do the test because moms was tested positive early in the pregnancy, but when tested just before the delivery, they were negative. So the mom is negative. CDC and AAP recommends no need to test for the babies. So we have not tested. Again, this recommendation has changed from the AAP since we look at from the April until now. The latest guidelines from AAP is in the mid of September. The first they started giving guidelines in April along with the Red Book infectious disease group. So the symptomatic, the primary outcome when we looked at the symptomatic moms, again, some symptoms of COVID-19 infections in the absence of any other respiratory infection for these moms. Asymptomatic is, just test positive but no symptoms. The risk factors, when we looked at it, it was kind of like in a match with a lot of another papers. Pre-pregnancy BMI high, mom is having hypertension, chronic hypertension, it's not a gestational hypertension. And if she is having a diabetes, any, and some of like an abnormal biochemical profile, coagulation profiles, and the mom has a substance abuse. And then a couple of mothers we have in a maternal HIV, maternal syphilis, but these moms were not actually symptomatic. Maternal HIV, 2 mothers we have, syphilis, I think 2 mothers, they were not symptomatic. I'll just skip this slide. So the most common symptoms, what we noticed in these moms is matched with other papers which was published. Fever is kind of the most common symptoms, which is 68.4% of the mothers, followed by cough. So the interesting things, what we looked at is the pre-pregnancy BMI. The mothers whose BMI is high, which is 35.71 in the symptomatic group versus 26.79 mean in asymptomatic groups, which was statistically significant. And another interesting thing is the potassium levels when we looked at it, the low potassium levels were seen in the symptomatic group versus symptomatic. I don't call it as an it's not fitting into hypokalemia, but the mean is 3.7 versus 4.3, which was again significant. So we kind of looked at all these moms' placenta just to see, I mean, any special pathology is going on with the placenta. Is there any role of this vertical transmission? And then we had a long chat with the pathologist. Every slides which kind of we look closely, it's just all over the place. We all the different pathological findings were seen, which could be seen in any of the other diseases. For example, maternal vascular malformation, we can see if the mom is having a preeclampsia or any baby is having an IUGR for any reason, small placenta, we can see these kind of findings, which are also seen in a mom who is infected with COVID. The fetal vascular malformations were also seen. But only the interesting things which I would like to emphasize is the meconium associated changes were seen in the placenta than other findings. And also syncytial knots which was seen. Are they specific related to the COVID? For our pathologists, they said no, it's not. Is there the meconium was there when these babies were born? No, there was no meconium. However, the placenta showed the changes which is kind of seen in the meconium stain amniotic fluid. So this is from one of the months which was really badly infected, and then with her permission we are kind of presenting here. She died. So she was very hypoxic. We saw the laminar necrosis in the placenta. Again, laminar necrosis we see in all these HIE, hypoxic ischemic encephalopathy babies placenta also, if they have a really bad tracing before their delivery. Is it because of the COVID virus direct infection, or is it because of the hypoxia mom is having? Most likely, we would say it's because of the maybe hypoxia related rather than the COVID virus infection to the placenta. That's about the mom and placental changes. How these changes and then how these are going to affect the fetus, also newborns. I'd like to just talk a little bit about it. What do we currently know about the newborn risk for COVID-19? What are unknowns? What are existing guidelines? And our findings, what we do. So there's a lot of data which trying to look at, is the virus is there in amniotic fluid? There is no clear evidence. Again, we talked about a little bit of the placenta. The answer is kind of yes and no. I would say the literature is trending towards more towards a no than yes. Cord blood, people have seen IgG in the cord blood, but is it because of the infection? We are not sure. His mom is transmitting the immunity to the babies with the, in the terms of IgG. We are not sure yet. So the risk for the infants, a lot of unanswered questions here. Transmission of virus to the baby and mode of transmission, existing guidelines, protocols to minimize the risk of transmission from the AP. It's a method of clamping of the cord. Do we need to clamp the cord early? Or can we do the delayed cord clamping, which is kind of a standard of practice now? So now the AAP says, yes, we can do the delayed cord clamping. And people are doing cord milking as well. They are not restricting for the COVID mode. Separation of the baby from the mother after the birth. Again, it has started with one end and gone to the extreme other ends. When it started in March and April, we were separating the baby. Actually, we are taking the baby to the next room for the resuscitations when the mom is positive. Mom is positive, undergoing C-section or vaginal delivery, we used to do in a negative pressure room and take the baby to the next room. But now AP says, no, we don't have to. We can resuscitate the baby at the same room as long as there is 6 feet of distance between the mom and the baby. And detection of the infection of baby, when and how frequently we need to do. Then again, the timing also, there was a lot of talk going on, but now kind of we were came to one agreement, which I'll just go over the schedule, how we are doing it. And then what is the quarantine period? If mom is positive, baby bonds, when can she, take care of the baby like in a regular mother? And symptoms frequently observed in a baby. Differentiate COVID-19 related symptoms or non-COVID-19 related symptoms for these babies. AAP and then infectious disease people and CDC are regularly giving in a clinical guidelines and practice management. It's like, the site is changing every 2 months with some new recommendations and a lot of advocacy researches. Based on the initial recommendation from AEP are based on case series and case reports available on perinatal COVID-19 registry. The first report they published was April 2nd, 2020. The latest report from AEP was September 9, 2020. So based on those, 2% of infants born to infected women tested positive at 24 to 96 hours after the birth, which is kind of in a very less, from the positive moms. Existence of a few case reports on infants requiring hospitalization before 1 month of age due to severe COVID-19 infections. Limitation, no information of a stage of a catching of infections before or after the discharge. We don't know exactly yet. Is it like before or after, but especially for the babies who are discharged and coming to our clinics. And then it also provides a guidance on infection preventive measures, management of the newborns for their families. And then I think Dr. Dikshit has mentioned in our resource slide, it's an aap.org. It's almost everything is there in it. So protection against a maternal virus aerosol and potential newborn virus aerosol during resuscitation. Somebody was texting in a question earlier. So what do we need to do when we go for a delivery of an positive mom? I mean, a regular, as we are all doing, um, gown, just in a down gown, the regular gown, gloves, and N95 respiratory mask, and then a shield, eye protective goggles, or an air purifier respirator. Delayed cord clamping is AAP recommending, yes, and skin to skin contact initially in April and May. If you look at the guidelines, it says kind of no. Now it is yes, we can do it. Hospital discharge of the mother and infant. Negative tested infant discharged to family members or caregivers, or if the mom, I mean, we're recommending mom is positive, symptomatic. If anybody can take care of the baby, that's an ideal. But if mom says no, I mean, I would like to take care of my own baby, there is no indication not to separate the baby from the mom. The mom is symptomatic mother, can take care of the infant 10 days since symptom onset and 24 hours since resolution of fever without antibiotics. I mean, like a regular taking care, not like wearing gloves and mask and things and all. And other symptoms have improved with mask and hygiene precautions when the mom is kind of like still symptomatic during that period. A symptomatic mother and who is positive can take care of infant without precautions 10 days after the first positive RT-PCR test. This was one of my colleague in California. He published in April, but the things are changed. I mean, I just like to show how things are changing every month. When he published in April, it's according to AAP guidelines. There was no skin to skin contact at the times, but now they said yes. And then usually the delivery is in negative pressure room. Make sure we have the mask N95 for the mom. All aerolization procedures are likely, and delayed cord clamping, yes. And the resuscitation room, physician barrier, curtain, if needed, and then greater than 6 feet or 2 meters away, the resuscitator and the delivery area, and the airborne precautions need to be practiced. And then the other thing is during a resuscitation, the CPAP versus a bagging. I mean, the current recommendation is if the mom is positive, really symptomatic and in a positive, and then can we do a CPAP or can we do a bagging? I mean, TPs, yes, we are kind of AAPs recommending to do it, and then but whereas like in a bagging and doing high flow nasal cannula versus like in TPs, it's more inclining towards an TPs resuscitations than the other ones. If any questions, if his baby is kind of not doing in a well, better to kind of intubate, and then when the baby is coming to the negative pressure rooms in the NICU, based on how the baby status is, we are kind of extubating. That means like it's just to prevent the spread to the other resuscitation personnel. At that point, about the breast milk, there was yes and no about the breast milk initially when this paper was published, but now the AP recommended yes for the breast milk. The papers which I was presented earlier, they detected breast milk virus, but it's in virus particles, but not the live virus in the breast milk. Now the AP says the advantages of the breast milk are much higher than the risk of transmitting the virus to the breast milk. There is no solid evidence of this. I don't think I've read any paper. It's the particles which was the one paper they published, but it's just a particle, but not the live virus, they said. So currently breast milk is recommended. So this is something we looked at in our mothers when their mom was positive during a pregnancy, when the baby was delivered, when we checked the baby whether the baby was positive or not. So we have like these 13 moms, we kind of looked at it. This mom, the first mom, she was positive when she was 26 plus 2 weeks of gestation. She delivered a baby at 28 weeks. And at first 24 hours negative, 48 hours it is negative. Another mom, 33 weeks, 38, the 5 is. What we tried to look at is if the increase of the duration from the positive to the delivery, Was there any chance of this baby having an infection versus no? I mean, there's an indirect or surrogate marker for a vertical transmission. If you expose for more days, and then is it a high likely the baby get infection? Interesting thing what we found is none of these babies was as positive. The question in front of is, are we testing too early on these babies? We don't know. I mean, is it like in 24, 48 hours is too early? Do we need to wait for a longer to test that? But we are closely following up all these babies in our clinics. None of them were symptomatic. Nobody having any respiratory symptoms, or they're kind of doing fine. So which is kind of like, inclining towards vertical transmission is kind of less likely. So we looked at few babies with an IgM and IgG. We couldn't find anything interesting. They are kind of in the normal range. So the few of the babies does have any symptoms and then ended up in an ICU with the symptoms. One baby has an apnea. Few of the babies, 5 babies have increased work of breathing. Couple of babies have desaturations, hypoglycemia. One baby and 2 babies were poor feedings. One baby actually has a high temperature. But closely looked at all the other clinical data, 99% of these babies, they are attributed to other pathology like respiratory distress syndrome, rule out sepsis with mom as GBS positive was not adequately treated, transient tachypnea of newborns, just premature related apnea. One baby had a pneumomediastinum. One baby has a poor feedings because of the late preterms and hypoglycemia related to mom's obesity and birth injuries. Um, this, um, uh, uh, this slide shows the conclusions and recommendations based on AAP guidelines, just a summary. Transmission of virus baby and a mode of transmission. And I would say instead of absence of evidence, it's still controversial. I mean, the consent of existing literature, half the paper, not half, more than half the papers, there was no vertical transmission. Very few they are kind of questioning. That too in early papers like March and April. Method of clampings followed in existing CDC and AAP guidelines. Yes, for delayed cord clamping. Skin to skin contact. Yes. Detection of infection of the baby when and how frequently. AAP recommends testing of all newborns at 24 hours and 48 hours. But if one is okay, if mom wants to discharge less than 48 hours, I mean, because of the family issues we are coming across, all these social kind of things, mom wants to go home after 24 hours. I have any kids at homes and I have only one test. I mean, we are okay for them to, we are discharging, and then AAP said it's okay to discharge after 24 hours, provided you follow up them in the clinic. But it needs a close follow-up. Symptoms frequently observed in a babies born to COVID positive mothers. All, I mean, there is no specificity. I mean, we found fever, lethargy, rhinorrhea, cough, and tachypnea, increased work of breathing, but majority are asymptomatic and mildly symptomatic, absence of requirement of any respiratory support. Infant with underlying medical condition and premature delivery, high likely to be severely symptomatic, requiring respiratory support. And is in COVID-19 is likely cause for these symptoms? It looks like highly unlikely at this point. And then we found a couple of challenging things when we get a lot of babies from other hospitals. I mean, mom is positive, baby is born there, but we need to transfer the baby over from there. How to do the transport? I mean, our fellows goes and pick up the baby from there, and she's needing some respiratory support. I mean, especially from NIPPV or some kind of a CPAP or high flow. If somebody is needing in a high amount of FiO2, we are recommending, when there is no clear guidelines, intubate and get the babies just to prevent the transmission to others. But again, if it is a very minimal FiO2 is like 23 to 30, and if we can get away within a closed CPAP, we are doing with that. But again, somebody's on NIPPU needing a higher amount of FiO2, but doesn't actually borderline for the intubation thing, we are to go ahead to intubate to prevent the viral spread to the other team. And respiratory strategy, if the baby is positive, I mean, as Dr. Shiva was mentioning, high vent settings with a high vent setting with a high PEEPs and CPAP and IPP, we are practicing everything in negative pressure rooms. Remdesivir, I don't have any experience, and I read a couple of papers, people who are trying. I don't know how effective it is in the newborn, but still we need more data on it. steroids, plasma therapy, immunoglobulins, anticoagulants in the newborn period less than 28 days, I don't think any enough data is there. It's all case by base at this point. Summary and future directions: low maternal mortality rate in a pregnancy, limited studies exploring COVID in a first and second trimester, vertical transmission not clear, infant born to COVID-19 infection, whether most are asymptomatic. Long-term effects, we don't know. Thank you.
Thank you so much, Dr. Janardhan Maidam. That was a very, very comprehensive review of COVID in pregnancy and newborns. Uh, that was really some review. Thank you.
Thank you.
All right. Once again, thank you to all the speakers. That was some really good presentations. I felt like I learned something today, really, from each one of the presentations. Um, I really have some questions for you, but before we go to my questions, let's go to the audience questions. Most of these questions, I think Dr. Maidam already answered some of them. Uh, but the first question is, what is your recommendations to newborns when mother is symptomatic with mild to moderate symptoms? It's probably for Dr. Maidam.
Um, we we are not isolating the baby from the mother. If the mom wants to nurse the baby, breastfeed, room in, that is acceptable. But when we go and examine the baby, again we are maintaining that social distance of 6 feet and full attire of PPE, examining the baby. But we are giving a very strict um, guidance to and instructions to the mother. She has to wash hands, wear gloves, wear 95 N95 and shields while she's breastfeeding and taking care of the baby. If possible, we are putting an isolate in the mom's room. But again, I mean, we do recommend, if anybody family member is there who is negative, can take care of the baby. I mean, she can express breast milk and then we can feed the baby. And we are having in a two different answers. Some of the moms are okay with that. Some of the moms say, no, I want to take care of my own baby. I'm fine even if she get infected. We have to just document and then give value to her wish. Again, this
So
has changed from March, April to now. Currently, skin to skin contact, taking care of the mom, baby by the moms is all acceptable by AAP.
absolutely. As Dr. Dikshit was mentioning at her talk, at the beginning of her talk, the recommendations at the beginning of the talk may change by the time the talk was ended. So it's ever evolving process with the recommendations. So you guys are placing the newborn babies in the isolate in mom's rooms?
Yeah, I mean, that's one options we are considering. If mom is really symptomatic and coughing and having a high grade fever and all, I mean, one-to-one nursing will be there. But again, most of the times the nurse will be sitting outside the room, but the thing she's watching closely, helping the mom. But yes, yeah, well, that's one of the options we are considering. Yes,
Great.
even for the term babies. Yes.
Thank you. Next question is probably for Dr. Dikshit. What is a guideline for a healthcare worker? If a physician sees a child today for a routine office visit, and then 4 to 5 days later, patient tests positive for COVID-19.
Yeah, so can you guys hear me? Sorry.
Yeah.
So I think we usually defer to our occupational health and infection preventionists, and you always following the CDC guidelines, and I believe they have been updated. And honestly, I haven't checked the guidelines in the past few days, and as you just said, they change every day. But I believe it's only up till 2 or 3 days before symptom onset. So if somebody was in contact or close contact, as it is defined, with a known patient up until 2 to 3 days before symptom onset, then they are considered exposed. That also depends on what PPE was being used. Healthcare setting is a little bit different than community exposure. So in the absence of PPE, if the patient was symptomatic 2 to 3 days after exposure, is check that duration on the CDC website, please. Then I believe the exposed personnel would have to be quarantined and tested, but not more than that. There's a specific duration.
is still the less than 6 feet and is exposure defined as less than 6 feet, no barrier protection,
Mhm.
and for more than 15 minutes. Is it
Right.
right?
And they actually, I think literally like earlier today updated it to be total 15 minutes in a 24-hour period. Even if it was like, 1 minute, 1 minute, 15 times. But if it was a total 24-hour period, then it still counts. But yeah, I think the key in the healthcare setting is what was the PPE. For example, we are always in COVID-19 positive patients room, but we are usually the ID team is going in after the diagnosis has been made and everything. So we are always in our N95s and completely covered. So we never actually have to go get, we have to monitor our symptoms every, like, because the EMR will pick up our exposure, since we entered the room. But we are not considered exposed because we are in complete PPE, even when we are, examining the patient close up. So healthcare settings are a little bit different than community settings in that sense.
Yeah, yeah. So another question about newborn exam. Do you have any recommendations about newborn exam in the room versus outside the room for COVID positive mothers? I know who wants to take a stab, Dr. Maidam or Dr. Dikshit.
I think the first question is the newborn still a PUI? So if the newborn is still a person under, investigation for COVID, then you can't bring them to a nursery and expose other babies or other staff. They have to be in the negative pressure room. If the newborn is not a PUI, then I think standard precautions apply. If they are separated from the mother, then you follow non-COVID precautions, whatever they may be at the institution. If they are with the mother, then the mother should be under precautions in a negative pressure room. And then in that case, you would, wear your full PPE if you're examining in the room. So I think it varies institution to institution based on what resources you may have available to you and whether the newborn is still a PUI.
Absolutely. I think some of the audience expressed concern that the uh, postnatal rooms may not be that big. Like you cannot just physically have 6 feet distance between mom and the baby. And when you're examining the baby, you may not be able to maintain that distance, which is like practically speaking, that's completely true. But again, that's unfortunately that's the world we're living in. So I think in my hospital, the for the babies who are born to COVID positive moms, the pediatricians are bringing those babies out of the room into the procedure room and examining them. That's what our hospital is doing. Um, Again, it changes from place to place and local guidelines and all those things. Uh,
Again, I mean, what we are practicing, Shashi, is again, if mom is positive, she's kind of treating totally different, like, separate room, or, and again, negative pressure room for the baby, so that, the pediatrician or we, morning rounds, we are going into the room and examining, and not trying to expose that baby to, in the nursery or in the ICU. But we do have a separate procedure room. Sometimes we bring that, provided, like, if mom is is not in negative pressure room, or it's kind of like, not that much distance. It's very combination, but 95% of the times she's in a separate room, isolated room.
right, right. Okay. All right. Question from Dr. Janal Gadda. Zika virus and COVID act same to cross the placenta. Why the incidence is more in Latinos?
Latinos are high. Again, reason we don't know yet, but most of the moms Latinos, what we looked at it, especially that age group, 25 to 30, BMI is kind of on the higher side. Is it the BMI, as it is the race and ethnicity itself, are they more prone? At this point, we don't know the answer. I mean, it's just a speculation. It's because of the BMI, but that's like, very crude guess, I would say. There's
I would
no.
like to add, sorry.
Yeah,
I didn't
yeah,
mean-
go ahead. Go ahead.
I would like to add that I think there is a big player here is the social determinants of health, and these, Latinx and other minorities are more likely to have occupations where they are not able to work from home. They are being exposed in their workplace during public transport, and at least in the pediatric cases that we are seeing, it is the multi-generational households. So the father is working, or and they have high risk grandparents, and the father brought it in, got tested positive, transmitted to the mother or the baby and the grandparent. And so it's unfortunately, I think, just socioeconomic risk factors that is more, there's structural racism. There's just a lot of players that are beyond, I think, the immediate like BMI might be one factor, but I think there's a lot going on beyond the direct, health related factors.
I think completely agree with you, Dr. Dikshit. Social determinants of health are primarily, they just like pandemic kind of like magnified the impact of those factors on your health really. Certain demographics getting affected more. Uh, Poorer communities are getting just like stamped by this virus and all those things. So yeah, absolutely. Um, a compliment and which is getting a segue to a question to Dr. Oruganti. Very well presented, Dr. Shiva Oruganti. It is multidisciplinary effort and emphasized so well, which is Dr. Oruganti did so well. I thought so too. Um, Again, UK being a centralized healthcare system, very, I think they are very well organized, better organized than here, having practiced in both the countries. I think I can say that. Um, Shiva, you talked about dexamethasone, using dexamethasone. As a pandemic is evolving, again, even in adults, even now, there are like so many different doses of dexamethasone. Do you guys have any specific dose in mind that you guys use?
No, there is no specific. In the dexamethasone mainly was looked at in the recovery trial, and we are awaiting a specific recommendation from the RCPCH. And as of now, all we know is that we haven't had any reason since the outcome of the recovery trial about dexamethasone. So it's just up to individual practice. But we are hoping in the next couple of weeks, maybe by beginning of November, we'll have a recommendation from the RCPCH. I know that in adults, they used 6 milligrams of dexamethasone, which is not a very high dose actually. And what I use is anything between 0.15 to 0.5 milligrams per kilo in pediatrics. And of course, with an upper limit of 6 milligrams.
I'm sorry, how much do you use? I'm sorry.
0.15 to 0.5 milligrams per kilo of dexamethasone, but that's again there is no evidence for that.
Like is it per day or
per day? Sorry, per day. Yes, per day. Yes.
Sounds good. Again, this is like a weird disease. If there is any new disease, kid on the block, you're more worried about like pediatrics. There are like certain high risk demographics like pregnant women, pediatrics, and somehow this disease, hopefully it holds true forever, is sparing kids really in a way. Uh, I have a question for Dr. Dikshit. Um, you really very well explained the ACE2 inhibitor attachment and receptors and all those things. I did a similar presentation a few months ago for the GAPI, the Global Association of Physicians of Indonesia. At that time, that was like probably 3-4 months ago. At that time, in my research, I came across that the ACE2 receptor expresses less frequently or less commonly in children with atopy and allergic asthma. And I think NIAID was also doing a study with 2 arms involving some kids with allergy and asthma and following them and how those kids are getting affected with COVID compared to their peers. Do you have any comment on that? Have you come across any?
I'm not familiar with the data that you're mentioning, but it's a little counterintuitive for viral infections that we expect children with asthma to have more sort of serious manifestations, and I believe it is considered one of the underlying conditions that puts them at higher risk for severe COVID-19. So I would have to look into more detail as to the study that you're describing, and the data that I presented, I actually don't know if they looked at the a difference in A to B and children with asthma when they looked at the expression of the ACE2 and TMPRSS2. So I will get back to you. Let me look into it.
No, that's okay.
Yeah.
I thought that was like really interesting that these kids are getting protected in a way because of the lack of ACE2 receptors on the cell.
That would be interesting. That would be interesting because I think it's a little counterintuitive to my understanding of how viral infections affect children with asthma, but maybe there is very specific reason for that in COVID-19.
Right. Any other questions?
I just wanted to share that, we mentioned remdesivir. We have experience using it at our institution. The youngest, I think, child that my team, while I was on service, recommended it was, I think, less than 3 weeks old. And some of those numbers were included in that data that I shared with the compassionate use. So we had access to it in the beginning through the compassionate use program, which then became an EUA. And then now we have the clinical trial. We still have the option to do the EUA. So if a family doesn't want to risk being randomized to the control, or if they don't want to be a part of the trial, they can still get it through the EUA. And in our experience, infants also have tolerated it very well without any major side effects. Nobody had reasons to discontinue it because of rising liver enzymes. And in fact, often we were at that 4-day mark, 5-day mark, the baby might even be ready to go home. This was before the 5-day duration came in. It was still a 10-day duration that was being recommended. And we would just stop because they were doing so well that they would be going home. And we would have started it while they were actually almost in the ICU, getting started on oxygen and things like that. So, we have used it and have had, anecdotal experience. I can't endorse widespread use based on this, but in our experience has been useful and no harm.
Right.
So Dr. Ishi, they were neonates, right? I mean, less than 3 weeks, you said.
Yeah, they were not, sorry, they were readmitted. So community acquisition, whether from the family or whether from the, we don't know if the mother was positive at birth. She wasn't tested at the time, or we didn't have testing on the placenta or anything. So we don't know, but our suspicion is that it was postnatally transmitted in the community setting at home. We actually published a series of four neonates that we had early in March and April. So they all did very well. Only 2 were serious enough to need remdesivir.
So all of them less than 4 weeks, you say?
Yes.
Oh, okay, great. And then what was the presentation?
So they all presented with the fever, and then all of them had to undergo sepsis rule out. 2 actually had co-infection. 1, I believe, had a bacterial infection. I can't remember which one. I want to say E. coli. I can send you the paper. And the second one had human metapneumovirus. And in fact, our excellent PICU colleagues were with the human metapneumovirus co-infection. We thought that was the major driver of the patient's symptoms, and we didn't, even though the patient was admitted to the ICU, we did not end up using remdesivir for that patient. So they generally did well though.
You found
Dr. Dikshit,
sorry. You found them helpful?
Sorry, say that again.
Did you find them helpful, remdesivir? Like, did it help them? I mean.
So it was, we have not had any bad outcomes from using remdesivir or even from COVID-19, generally speaking. And it's obviously hard to say. We don't have a comparison group. Like, I don't have a control group to tell you, but we tend to have we would usually start it early, as soon as kids thankfully came to attention early. And so maybe helpful, like Dr. Shiva was saying earlier, maybe helpful early in the disease, exactly for the reason that he mentioned. The early phase is what is driven by the viral replication. And then almost all of the patients who are severely ill or critical do end up getting dexamethasone after discussion. We have also used anakinra in some more severe patients. MIS-C patients almost always get an immunomodulator. We have used convalescent plasma in a few patients. Again, no adverse. We always worry about that theoretical antibody-dependent enhancement of the infection. So, it would be a big team discussion, big family discussion, but every time we've used it, we have not had adverse events that we could attribute to the therapies.
Thank you.
I have a question for Dr. Dikshit. I think I was going to ask you about the temporal relation between starting remdesivir and the severity of illness, but I think you clarified that. Maybe, it's my gut feeling that perhaps using earlier would be more beneficial rather than wait until they are severely unwell with organ failure. The question I have now is, I think we are using in the recovery trial as well, there is tocilizumab, which is an interleukin-6 antagonist. And more recently, I saw a systematic review which more or less found evidence from different studies that at the beginning, COVID was called like a cytokine release or a syndrome, as you see with CAR T therapy or any other inflammatory syndrome. But again, the interleukin-6 levels were very low. Have you used tocilizumab yourself, or what are your thoughts about that?
Yeah. No, I don't think our institution has used tocilizumab. All of our immunomodulatory therapy, at least specifically the IL-6 and IL-1 inhibitors, or even JAK-STAT inhibitors, are usually given under our rheumatologists' recommendations. And their group has typically recommended anakinra whenever we have thought about using one of these immunomodulators. So I believe we have not used tocilizumab. Obviously, I've not seen every case of COVID-19 at our hospital, but as far as I know, we have not. We've used anakinra, and we've used IVIG for MIS-C, and but I don't think we've used any other. I think it depends on the panel. Like the rheumatologists will ask for the panel, and they may use something else. But in my experience, I've always seen them use anakinra.
Thank you. Yeah, our rheumatologists seem to believe that tocilizumab doesn't really help, and this was right even before the systematic review.
Right.
But I think they were hedging their bets more on anakinra, which is the interleukin-1 antagonist. Thank you.
As you may know, there's that ID week going on right now, and I think everything that's come out on the day one today is not in favor of tocilizumab, as far as I know. But still under study.
Thank you. Thank you. And thank you. It was really great, Sashi. Great opportunity for me, and I would like to thank Dr. Dikshit and Dr. Maidam as well, despite being unwell. And apologies for jumping the queue, Dr. Maidam.
Oh, no.
It was very interesting listening to you both. I hope you guys don't mind if we stay in touch, just to share any interesting articles or anything like that. And thanks for posting the online resources.
Thank you very much. Thank you, Sudhakar, RP President. Thank you, Shashi. Fantastic moderation today and bringing in the great speakers. And thank you, Dr. Organti. I am really hats off to you. You are almost 4 o'clock in the morning in UK. Thank you very much for joining us. I'd love to meet you when the skies are open, okay? And being a fellow Rangarayan, I'd love to see that. Dr. Dikshit, beautiful, excellent talk. Thank you very much. Thank you. And Dr. Maidam, you had a fantastic discussion today about neonates. And this is the first pediatric seminar for RP webinars, RP point of view, and because we are always hitting hard on adults, COVID patients. Most of our members are PhDs now about adult COVID care, regarding COVID management, everything. The first, as a gastroenterologist, I had a crash course today about the peds. Okay, thank you very much for joining us today. Good night. Bye.
Thank you all. Good night.